Set the standard for neonatal care with Policies, Procedures, and Competencies for Neonatal Nursing Care 6th edition. This book includes 24 policies, 29 procedures, and 31 assessments you can adapt to guide patient care and support your team's practice. Order now for your group or institution and build a strong foundation for neonatal nursing excellence. Learn more at ilearn.nan.org. Hello, and welcome to NANNcast. I'm Jill, your host. What happens to our NICU patients when they grow up? As neonatal clinicians, we spend our days focused on the earliest moments of life, helping premature infants survive and thrive through those critical first days, weeks, and months. But how often do we stop and think about what prematurity might mean decades later? Joining me today is Dr. Michelle Kelly, a dual-certified pediatric and neonatal nurse practitioner, professor, and co-director of the Mid-Atlantic Center for Children's Health and the Environment at Villanova University's M. Louise Fitzpatrick College of Nursing. Dr. Kelly's research focuses on the long-term health outcomes of people born preterm, including how environmental exposures, poverty, and toxic stress may influence health across the lifespan. She also continues to serve vulnerable populations through her clinical practice as a volunteer pediatric nurse practitioner. As NICU nurses and providers, we're uniquely positioned to influence a child's health far beyond discharge. The education and guidance we provide, from promoting healthy behaviors to helping families understand the lifelong implications of prematurity, can influence outcomes long after a baby leaves the NICU. This conversation may change the way you think about the lasting impact of your role and the opportunities we have to support children and families well beyond discharge. Let's get right into it. Michelle, thank you so much for joining us today. I think a lot of NICU nurses spend so much time in their NICU caring for premature infants that we really don't see or get the opportunity to see those patients decades later. And your research really focuses on connecting those early beginnings in the NICU to how that affects health across their entire lifespan. What led you to begin studying the long-term health outcomes of people born premature?
Well, I am actually a reformed pediatric nurse practitioner. I started my journey as a nurse in a PICU, in an acute care setting at a major children's hospital. Went to graduate school to become a pediatric NP. Realized very quickly that the acute care setting for peds is really, really vast. And then through just some bizarre chain of events, I found myself working as a neonatal nurse practitioner. When I was in that process, I realized pretty quickly that those two disciplines don't necessarily talk to each other the way we would hope they would. So when my peds colleagues really don't have an idea what happens in the NICU, and my NICU friends really didn't have an idea what happened in primary care. And my first, major publications were about the care of NICU grads in primary care. And then that sort of evolved as that group of kids that I studied during my doctoral work, as they got older, I realized nobody's really talking about this, and there aren't enough of us talking about, well, what happens when they're 15? What happens when they're 18? What happens when they're 23? And then I had the opportunity to meet Mary Sullivan, who is a maternal child nurse who worked at the University of Rhode Island, who has the longest continuously followed group of preemies. And I was able to do a postdoc with her, so a postdoctoral fellowship with her at the University of Rhode Island, and met 30-year-old preemies who had been followed by her, a control group of term kids that were born in the same era, and her preterm kids. And really, I fell in love with that population. Even though I don't really like to take care of adults, I really was fascinated by their stories.
I liked how you mentioned how we all kind of don't know what everybody's doing. We sort of work in our silos. And I feel like the NICU population is kind of invisible, so to speak, and especially once they leave our NICU. Why do you think that premature infants have historically been overlooked as they grow older and continue their life through our healthcare system?
So there's probably two reasons for it. One is human nature. We want to normalize kids as quickly as we can. The primary care team wants to get them off special formula. They want to make them, reassure the parent that everything is fine and their child is progressing. And we've come so far in neonatal care that, they actually, for the most part, kids really do well originally. But one of the things that I have talked to parents about is, it's not really all that hard to be a 6-month-old. It's not really all that hard to be a 1-year-old. Second grade math is hard, right? Second grade math is borrowing and carrying. That's very abstract concepts. So that's executive function. That's that next level up. And sometimes we don't realize that our kids are starting to struggle with some of those neurodevelopmental things because they run, they play, they walk, they talk, they do all of the things, but it's that higher level that starts to challenge them. And we tend to follow kids until they're 2 or until they're 4, maybe until they're 8, right? But we stop following those preemies after that because, hey, they're fine, right? They may not have a connection to the NICU anymore. They may not, their primary care providers, whether it's a nurse practitioner or a physician, may not be attaching preterm birth as an ICD-10 code anymore, right? Because we've normalized the child. We've made, they're just Tommy. They're not, Tommy the preemie anymore. And if we as NICU professionals don't remind parents to keep telling the story, then the story stops being told. Right. So when I wear my primary care provider hat, which I still do sometimes because it's hard to work in the NICU when you teach full time. And if I can't put a tube in a 23-year-old or a 23-weeker, I have no business being the nurse practitioner in the NICU. Right. And that's something you need to do all the time. So primary care is a little easier for me to jump in and out of. But when I work as a primary care provider, I tell parents to tell that story, to say that, my son was born at 30 weeks and he is doing fantastic and he's making all of his milestones. But if you notice anything, please let me know. Because what I've learned in my research and focus groups with school teachers is that most school teachers don't know which kids in their classroom are born preterm. And so they can't use that as part of their risk stratification or, even consideration because they don't know. So because, kids that were born preterm aren't diabetics who need insulin. They aren't, they don't have a sign on their forehead that says, hey, look at me, right? All of those things mean that we can't pick out the preemie in the room, right? But if I tell you that the average US classroom has 4 preterm kids in it, when I tell that to teachers, they go, oh, and they go, I bet it's, and they can list off kids because there are some behavioral types that have been associated with prematurity, and it's not the disruptive kids. They're the kids that are quietly making do and are unfortunately ignored in the classroom. And that comes from us trying to normalize and just, take away all of that vulnerability that they went through as newborns.
Yeah, exactly. Like they're taking that journey with them forever. It's not just, oh, you are a graduate of the NICU and you are done. Like that's lifelong. And I think now with so many advances in neonatology, we're going to see it so much more frequently because we have the means and the ability to save younger and younger babies, and the age of viability is going down. So with that, comes a lot of issues that we have yet to really see. I know that your research also looked into a lot of the health implications that premature infants are facing once they leave the NICU. Can you tell us a little bit about what your research showed and what kind of things that these premature infants are facing in the future?
So the biggest one is, as you would expect, respiratory complications. And what we have found, my research and others, is that children who were born early, whether they were ever diagnosed with BPD or not, have decreased lung functions as they age. So normal lung function trajectory is that you're born, your lungs keep growing, you plateau off for a little while, and then the average adult starts to have a gradual decrease in lung function in their 40s or their 50s. What we're seeing with preterm kids is that gradual decline starts closer to their 30s. So that's significant, and that's an issue. It's an issue for the adult pulmonologists, because they really need to be pulled into the conversation, and we need to have. Right now, we do not have, not here in the U.S. or internationally, a good set of guidelines for routine surveillance of preemies for respiratory, respiratory function, or spirometry or PFTs, or even some of the newer stuff is like lung MRIs and stuff. And that's a science that is evolving and is a little bit beyond me. But the message that I keep sending is we need to keep following them. They need to have some type of follow-up so that we can catch that drop off, or we can predict it, or we can start to figure out what respiratory meds are best. Some bronchodilators don't work as well for preemies because, that lung restriction may not be asthma, right? It's really preemie lung disease. It's not asthma. We call it asthma, right? We say that preemies have asthma. The physiologic process isn't the same. So they don't respond to the same meds the same way. And so there are some really fantastic pulmonologists who are working on this. The Children's Hospital of Philadelphia has a chronic lung disease conference every year. I was there last year. I was fascinated by the science. But there are people starting to have this conversation now. Like, how do we treat them best? And more importantly, how do we prevent it, right? Because one of the problems with prematurity, and anybody who's worked in a NICU knows this, gestational age, birth weight, and severity aren't enough to predict outcomes, right? You can have a 23-weeker who you thought was not going to do well, who comes back to visit you when they're 6 and they're rock stars, right?
Mm-hmm.
You can have a 32-weeker who you thought was going to fly, who doesn't, right? Who gets every complication, who gets readmitted to the hospital a bunch of times throughout their childhood. So those three things that we like to hang our hats on, gestational age, birth weight, and severity, don't tell us enough. One of the messages that I'm trying to send to the NICU world, really, is that you really are the most trusted provider in that baby's life at this point. If we can start that message early about reducing environmental risks, about reducing exposure. So not in the beginning while you're resuscitating a child, right? None of this conversation is happening then. This is the, feeder grower getting ready to go home. We've got a lot of time with the parent talking about the things that will help keep their child the healthiest, right? Vaccines, limitations of environmental risks like smoking or vaping. Maybe this is the kid that shouldn't be a firefighter, right? But the question you actually asked me was, what are the other complications? And while I went down this whole respiratory rabbit hole, the other thing that we recently did a study surveying adults who were born preterm, and we asked them what their chronic conditions or symptoms were. Respiratory absolutely was number one. Number two was anxiety and depression. And so those components are really important. So supporting mental health, giving them strategies to cope with some of the neurodevelopmental insults that they undergo while they're preemies. And then other things like behavioral conditions, so autism and ADHD are pretty high up on their reported risks. So they're all things, again, that are somewhat modifiable. So if we give them support and strategies throughout their childhood, we can help reduce how that affects their lives. Or, one of the things, one of the qualitative responses we got from a participant in one of the studies said, I just wish I knew that I wasn't alone, that there were others who are experiencing the same thing, and that maybe this experience is because I was born early. So those are the kind of things that I think we need to tell parents they could see. Not guaranteed 100% you're going to have these problems, because we don't want to make kids vulnerable, but yet giving them the potential, right? I always kind of do the worst case scenario, best case scenario, and the reality is most of us fall in the middle. So we're going to hit some buckets of those middles, right? And I think people do better when they're prepared.
Mm-hmm. Yeah, and I think that your findings are really striking, because it solidifies, like you had said, the story doesn't just end at the NICU. And to provide these parents with the anticipatory guidance, right? We always learn about that in nursing school, but we need to set these parents up for that, because, on the other end, what's also concerning that you mentioned earlier is there aren't many other healthcare providers out there that are asking these questions to these parents or to the children as they age, to know that their pulmonary functions could start decreasing in their 30s as opposed to a term child. They need to be aware of that, because maybe we can start checking early or whatever, instead of waiting until maybe we could have intervened earlier. So how do you find that balance where you don't want to terrify the parents and have them, looking at through a microscope at every single thing their child does, but also to be aware?
Yeah.
Or just be an advocate, right? Just say like, hey, my child was born at 25 weeks, just so you know.
Yep. I think if we package it the way we package like anticipatory guidance about, cold, flu, and snot season when they're going home, right? We tell them, or in my NICU experience, I always used to say that I had broad shoulders and they could blame anything they wanted to on me. So use that phrase. The NICU nurse practitioner told me you're not allowed to kiss my kid, right? The NICU nurse told me you can't come over if you have flu symptoms, right? Those kind of things. And if we can give them that power to be an advocate, to be, the protector of their child, even after that immediate discharge home, but, extend it out a little further and say, you know what, you always want to tell people that this is part of their story. And I think, it's kind of like the seatbelt rule. How did we get seatbelts? How did we get people to start wearing seatbelts when seatbelt laws first came into effect? We told the kids that they had to wear seatbelts. And then the kids guilted their parents into wearing seatbelts, right? And the change will happen because families keep advocating, right? I've talked to a lot of providers, physicians, nurse practitioners, PAs, talked to lots of them. They all kind of looked at me with that tilted head and go, what? Because what I'm saying to them is not necessarily what they were taught in school, right? I became a nurse practitioner in 1997. I was told that preemies catch up. Those that don't catch up are obvious, and everybody else you don't have to worry about, right? When I use that as a myth buster, when I give talks about this, the docs and nurse practitioners in the room shake their head because they're like, yeah, that's what happens. And I go, but it doesn't.
No.
It's so much more than that. And so changing that paradigm, right? Changing that concept of how we address prematurity is going to take a paradigm shift. It's really going to take a groundswell. It may have to come from the NICU nurses and then, educating the families so that the families keep educating their future providers. So on the APAN website, we created some like a one-pager, right, for adults that were born preterm to take to their providers with them. And it has some references and some guidance because most of the time, most adults have never been asked, right? If you're not pregnant and it's your OB asking because people who were born preterm are more likely to deliver preterm, pretty much everybody else has never been asked if they were born preterm. So you have to be prepared to share that information, right? You meaning the families and the people who were born preterm themselves. And I'm really deliberate, and I've had to change the way I speak in talking with the adults that have been born preterm. I stopped using former, right? Ex 23-weeker or former 23-weeker. I stopped using that language because just that language alone makes us believe that they stop being a 23-weeker. And the reality is they don't.
And that's what we say all the time.
Absolutely.
Between each other, but also when we're having conversations with our families.
Mm-hmm.
And you're right. That's a powerful way to word it instead of saying ex or former.
Yeah. To just say, Susie is a 23-weeker who is now 40 years old. Right?
Mm-hmm.
That's a thing. One of the participants in the recent study said that she had a provider go as far as to roll their eyes when she shared that she was born at 23 weeks in 1990.
Well, that's someone that doesn't get it.
Right. And so, that's part of this movement, right? To try and change the way we think about it, to relearn what we have learned.
Yeah, and I think that that's why it's so important for NICU nurses, NICU providers, anybody that shares our space in the NICU to be aware of this. Like I said in the beginning, I think a lot of us think about sort of the challenges that they're going to have after leaving the NICU. Like, how are they going to do with feeding? How are they going to grow? And those are the obvious factors. But many people, as you know with your research, don't know that. And I think we need to look at prematurity as like an important, earliest, most important factor that's going to affect their health for life. And, if you can help families and even your coworkers and everybody that shares the space, that's going to really change that perspective and really help with education with these families to ensure that this isn't lost. And this is part of their medical history. And not a graduate anymore.
Yeah. If I were queen of the universe, right? And my kids, I have 3 20-somethings, so sometimes I am queen of the universe. If I could change one thing about healthcare, it would be to add preterm birth into those like big 5 past medical history questions, right? Family history of heart disease, family history of diabetes, cancer, family history of prematurity, or personal history of prematurity. If we could make that be a documented part of people's history, first of all, my research would get so much easier because we can't, you can't data mine in the United States. You cannot data mine adults who were born preterm out of electronic medical records because those records don't go back that far, A. And B, it's really hard to find birth records of people that are over 25. Most hospitals purge them around 22. So it's hard to find the data and we don't track it. So we can't. It's why most of the research is coming out of European and Scandinavian countries because they have birth cohorts and they have national patient numbers and you're able to look at larger cohorts than we can.
This fall, NANN is heading to West Palm Beach, Florida. This year's conference will emphasize beauty in medicine, the innovations that make high-quality care possible, and the professionals who bring mastery to their units, all with a fun twist of artistic attendee events. Head to nann.org/conference to register now and take advantage of early bird pricing. We hope to see you there. So that brings us to what are some of the next steps in this area of research? And like, what kind of questions do you feel still need to be answered?
So, I think we've gotten to the point where we have to stop saying that we need more research to identify what types of conditions exist. So the research now needs to shift to how do we treat it best, right? So we talked a little bit about the pulmonary medication choices and pulmonary surveillance, but we also find that people that are born early have hypertension early. So particularly women have an increased risk of hypertension. And there's some work coming out by Dr. Kara Gross looking at which medications might be best. So which antihypertensive medications might be best to address the hypertension that preemies have as adults. And that's a really important piece. There's also a fair amount of literature out there talking about some joint pain and some pain syndromes that are happening with people that are born early, and whether that, I don't know that the science has evolved yet to really get us an idea of what the causes of all of those are, but we definitely need to look at that as a component and how to best treat them. So moving from identification into treatment, I think, is really important. I also think that we have to step away from, and I'm going back to pulmonary here again, we have to step away from BPD as a diagnosis, not as a diagnosis, but as a gatekeeper. So a lot of people, if the child doesn't have BPD as a diagnosis, they assume they're fine. And what we know is as our respiratory care gets better, we have less kids that have BPD, right? But those kids still have smaller, underdeveloped lungs that have the potential to have some damage and some scarring. And we really need to step away from that. Some of the providers are trying to coin the term preemie-associated lung disease as opposed to BPD or CLD, right, chronic lung disease, but really attributing it back to prematurity. So what I've learned from interacting with the adults is that a lot of them carry a diagnosis now of COPD. So they're diagnosed as having chronic obstructive pulmonary disease. But when you talk to the adult pulmonologist, they'll tell you they have COPD, but it doesn't respond like COPD, which means it's not really COPD. It's preemie-associated lung disease. And that's a whole really evolving, I think in the next 5 years, we're going to have some really good guidelines and some good components of that can help direct the care for people long-term. And the other thing is that I can't spend as long as I do with adult preemies and listening to their stories and not say that what needs to come next is that we really start listening to them and we start understanding that their lived experience needs to inform our healthcare choices. When I looked at this most recent cohort, we split the cohort up into pre-surfactant and post-surfactant. So, I kind of used 1990 and split them, into birth years to look and see, because that's always an argument, right? Well, we don't need to follow them that long because what happened to the pre-surfactant kids isn't relevant to what we're doing now. Our treatments are better. Yeah, but the data actually is pretty common. The same major conditions, there's really no statistical difference between whether they were born pre-90 or post-90 in terms of the long-term adult conditions that they have. And that makes sense, right? Mm-hmm. Because the kids that survived post or pre-surfactant were older preemies, right? Mm-hmm. So they're a lot more like our younger preemies now, right? Because they had to be strong enough to get there because they didn't have the same level of treatment that we have. So I think it's worth and really important to follow people long term and see how prematurity affects them across the lifespan.
And I think it's really important to have these conversations because, like you said in the very beginning, NICU providers, especially nurses and APRNs, are one of the most trusted healthcare professionals. And for us to be, armed with this knowledge and to be able to share that with our families and also other colleagues that might not be aware is so important. And that really sets the parents and the child up for improved outcomes.
Improved outcomes. And to me, what I say is mitigating risk and maximizing potential. Right? That's what we need to do.
Perfect. That's a great way to say it. So as NICU nurses and providers, how can we spread that message beyond the NICU doors to all of the other providers that are going to continue the care?
So what I've been doing for the last 15 years is pretty much talking to anyone and everyone who will listen to me, and some people who don't think they want to listen to me. And so that's the first thing, right? Keep talking about this. Have a consistent message for your parents, right? And do that minimizing risk, maximizing potential conversation with the parents. Every resident and fellow and med student who comes through your NICU should get a version of this conversation or be told to listen to this, right? So that they are getting an idea of that the NICU doesn't stop at the NICU door. The NICU itself stops, but prematurity goes beyond the NICU door, right? So that's important. Nursing grand rounds, provider grand rounds, any of that, continuing ed piece, talk at conferences. Use my research, use everybody else's research, right? You can be I am happy to share the wealth with this because I want this message to get out there. So, having people continue to have this conversation. And I think when I started having this conversation with people, the wealth of research that came out of the Scandinavian countries during COVID, because they were, doing secondary data analysis, right? A lot of Casey Crump, who's at Mount Sinai, has done a lot of work with this and looking at long-term outcomes using these data sets. So we've moved past it, right? When I first started having this conversation, there was a lot of, well, maybe that's what's happening. We don't really know. We know what's happening. Now we know. So we need to start doing the education and changing the way people think. Talking to med students, nurse practitioner students, nursing students. I do a preemie seminar for undergraduate students here at Villanova, and we talk about this. We talk about, and we put prematurity into context because that's the other piece, right? Neonatology is a young subspecialty, right? When we think about how it has evolved in the last 60 years, right? JFK's son died at 34 weeks about 60 years ago, right? So he died of respiratory distress 60 years ago. And was 34 weeks. So that kind of puts that into context. And so we need to give ourselves a little bit of a break, right? It's not that we use bad science. We just use the best science we knew, right? And now we need to change it. Now we're learning the new science and we need to keep evolving with it and keep talking.
Well, Michelle, thank you so much for joining us today and sharing your work. Your research really reminds us, especially as NICU nurses and providers, that after they leave the NICU, they continue to grow, thrive, develop, and those early beginnings go with them forever. And like you said, the story doesn't end at the NICU, so it continues. So thank you for alerting us to all of this and making sure that, we provide the parents the knowledge and the power to support their babies throughout their life. So thank you. Make sure you never miss an episode of NANNcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.